As part of Maternal Mental Health Awareness Week, one of the challenges that women may experience is perinatal OCD. This is going to be the focus for this session. I'm Boggis-Rolfe, parent-infant psychotherapist at the Parent-Infant Mental Health Service. I'm delighted to have Dr. Fiona Challacombe with me as our guest speaker. By way of an introduction, Fiona qualified as a clinical psychologist from the Institute of Psychiatry and Centre for Anxiety Disorders and Trauma, King's College London, in 2005, and has worked in clinical practice in the NHS since. She worked for 15 years at the Centre for Anxiety Disorders and Trauma, where she developed and led a specialist service for parents with anxiety disorders. Fiona is a specialist in the field of anxiety disorders and perinatal mental health, and is an active clinical researcher in this field. Her research aims to better understand mental health difficulties and other stresses during pregnancy and the postpartum. She conducted the first randomized controlled trial of CBT for postpartum OCD, investigating treatment effects on anxiety and parenting, and has recently completed a trial of intensive therapy during pregnancy. And Fiona, you previously mentioned to me about your work with Maria Bovetta, founder of the organisation Maternal OCD, on revising the perinatal OCD guidance to the Royal College of Psychiatry. Fiona, you've conducted groundbreaking studies, but have also an ability to effectively communicate your findings and complex psychological concepts into understandable and relatable ways, which have been so helpful for me as a clinician. So, and no doubt for the audience. So I'm really delighted to have you with us. Can you start by just telling us what led you into this area, specialist area?
What a kind introduction. Thank you so much for your words. And it's always a pleasure to be having the opportunity to talk with clinicians and peers and service users and people whose lives have been touched by perinatal OCD. So thank you for the opportunity. So it is a topic that I have really spent much of my career thinking about, and the origins of that were prior to my clinical training. I was very, very fortunate to work on a really groundbreaking trial looking at video feedback and intervention for mothers with eating disorders, so postpartum eating disorders. And that taught me a lot about research in this area. It taught me a lot about perinatal mental health and the importance of really conceptualizing and thinking about the specific nature of the impact of the psychopathology and the behaviors and thoughts and so on that are affected within a particular presentation and how that interacts with parenting. So when I became a clinical psychologist, I was really fortunate to have some great training with Paul Sarkovskis and really the leaders in terms of sort of cognitive behavioural treatment of OCD. So bringing these two worlds together, I started to really think about the impact of parental OCD, and that was my declin sci thesis, really asking about parenting for mums with primary school age children who had experienced OCD. And I mentioned to you before, at this time, perinatal OCD really wasn't a well described or known about concept at all. But in talking to these women, they were all women, asking them about the kind of course of their OCD, really one after the other mentioned, well, actually this started when I was pregnant, or started in the early postnatal period. And after really, 4 or 5 women had mentioned this, it really got me thinking about this concept and why the perinatal period might be a time of increased risk, and of course what would be the impact on early parenting. So I became really fascinated, and I was very fortunate to qualify as a clinician around then, so I was lucky to be able to do a PhD in that area that was then very clinically related and had a treatment element. So that's when it all kind of started in terms of interest in this area.
And can you begin by clarifying what perinatal OCD is, for the audience?
Well, there is no kind of official diagnostic term. In fact, so depression is the only one that really has a specific perinatal tag in the diagnostic system. So technically, it really is just the co-occurrence of OCD in the perinatal period, which, as we all know, is the commonly defined pregnancy up to the first or the second postnatal year. So that's a bit of service development aspects to that, but it has been up to the sort of the first year. So many women will have quite long-standing OCD, but for some, quite a significant proportion, they will develop OCD during that period. So I'm focusing on women, that's where the majority of the research is, but we also see that phenomenon in partners and fathers as well. So there's something about this, the perinatal period, which is this, I think, a combination of growing responsibility, of increased threat, and the combination of these things is really quite a heady cocktail for OCD to kind of jump in. So there's something about the perinatal period which I think does lend itself to this raised prevalence. And if people have previous vulnerabilities, quite often in that period, which, as we all know, is a stressful time for any parent, things can kind of breach that surface and start to become interfering. So yeah, so the perinatal period is probably a time of increased risk. But so it's just it's just OCD that occurs at this time, and it's usually, I would say, about something to do with the baby and caregiving, but not for everybody. And I would say that's really important to flag. That is still perinatal OCD, because the nature of OCD is that it impairs your function. It is preoccupying. It affects your behaviour. So even though it might not be specifically about the baby or about caregiving, although it usually is, for those people who are experiencing a form of OCD that might seem unrelated, there's still going to be some impact. There aren't many spare hours for parents, are there? So, I would think of it all as perinatal OCD. That was a very long answer to a short question.
No,
I hope that was okay.
And the prevalence of this really comes across in your research. Why is it important for primary care professionals, GPs, health visitors, to consider who are treating mothers? Why is early identification important? And what could be shared to inform maternity care?
So several elements there. So we think it's a slightly raised, slightly to very raised prevalence. So OCD is quite a common problem affecting kind of 1 to 2% of people at any time. So the most conservative estimates, probably at least 3%, 2 to 3% of women, if you take the very robust diagnostic criteria that some studies have been involved in. And what's really important about these studies is that they have asked about OCD phenomenon and kind of, checking intrusive thoughts and so on, but they've been very careful to ask about the infant-related intrusive thoughts. And those studies show a very high prevalence, about 7% of women at some point in the perinatal period experiencing sort of clinically interfering levels of OCD, including thoughts of accidental harm and thoughts of deliberate harm to infants. So these phenomena are really, really common, and we know that almost all parents will experience those kinds of thoughts, at least fleetingly, but for many they're very distressing, and for some they will be very distressing, persistent, and start to edge into OCD where they feel very stuck, and so on. So this contact with providers is so important. And it's those are the people who will have those first disclosures. So for people where everything is new in the perinatal period, it can be quite hard to judge what's normal. So it's a question I often get asked, like, what is normal anxiety? And of course, no one can give you a very, very clear answer to these kinds of questions. So whilst intrusive thoughts are normal, for some they are problematic. So we're kind of walking that nuance of, we want to validate and we want to reassure people, but for those who are stuck, that is also a difficulty. And so the most likely people to have that initial disclosure will be our, primary care workers, midwives, GPs, obstetricians possibly, and so on. So having that knowledge of perinatal OCD, intrusive thoughts, is really key to know when to kind of reassure, when to refer on, when it's not OCD as well. So having education about these topics, I think, is really, really important.
And actually, it's led me on to really, for me, it was so clarifying actually in that particular study, what and maybe you could sort of actually kind of further clarify the difference between unwanted intrusive thoughts of accidental infant-related harm and unwanted intrusive thoughts of intentional infant-related harm. And you mentioned how ubiquitous they are for parents. I think you mentioned that. Could you tell us a bit, clarify the difference?
Yeah, well, I guess we all have thoughts going through our mind all the time, and parents are often having thoughts about harm to their babies, because that's one of the key tasks of parenting, is kind of their safety. So by kind of this division of accidental and deliberate thoughts of harm, we kind of mean, where things pop in, and they could be images, they could be urges. I think quite often they are images. They could be verbal thoughts, but things that are sort of popping into our awareness that, oh gosh, something might happen to the baby. They could fall out of that, or I could drop them. So doing things that, the baby might be harmed in some way, but there's absolutely no intention. And where OCD is particularly kind of pernicious, I think, is that also thoughts of deliberate harm are very, very normal, very ubiquitous, maybe not quite as common as accidental harm. But I mean, I don't know if you've ever been on a train station or in the tube in a busy station, someone's sort of standing right on the edge. That would be really easy just to, push that person, or it doesn't mean that you have any intention. But we know our minds are capable of these kind of thoughts. And of course, parents' minds, which some of us are, also throw up those kind of thoughts. Like, gosh, what if I harmed the baby? And for some, those do come in the form of images as well. And again, we know these are very common in the general population in a fleeting way. But of course, if you're not aware of that, that can be very distressing. And it's where people start to question, well, why have I got that kind of thought? What does it mean? Gosh, what if I had some intention that I'm not aware of? They start to engage with those thoughts that then you get more of those thoughts, it becomes more distressing and more difficult. So I guess those are the kind of distinctions really, where it's all kind of the realms of threatening possibilities, I guess. But OCD tends to sort of throw a lot of mud at people until it finds something to stick, and those ones are, it tends to be, what's the worst thing that I could think of at this point? And for many, that is the absolute worst thing. And we know, the whole range of thoughts of harm are possible: violent harm, sexual harm, and of course, very difficult for people to get information that these thoughts are also quite common and normal. It's not the sort of thing that people tend to sort of chat about in their antenatal groups, and so on. So people are often left sort of questioning.
And a valuable point you've already referred to, I think, that was so sort of I should imagine so helpful for people to know, is the evolutionary basis for these thoughts.
Yes, exactly. I think what's the purpose of our whole anxiety system? Why is it that we're capable of imagining things which haven't happened? It's quite kind of phenomenal, isn't it? We can actually visualize and almost react to things which are created in our minds. And probably it's all part of this protection mechanism. And, evolution, I think, doesn't care whether we enjoy it or not. It's purely functional. So I mean, in fact, that's part of the mechanism, isn't it? So I think where, for parents have lots of thoughts about babies, there's some really interesting research about that in terms of kind of the amount of thoughts, particularly going up to that kind of 3 month. It seems to sort of peak around that period. And then, tail off a little bit for most people, that there's something there where, you know, we do need to sort of keep our eye on the ball, as it were, as parents. So that's the sort of evolutionary prod, I think, of kind of, you know, the biggest source of threat probably is us switching off or forgetting that there's a baby there or harming them. So there's something about, we think the mind is presenting these ideas as a way of going, oh, I don't want that to happen, but have another cup of coffee.
Yeah. The women I've worked with who have OCD, perinatal OCD, describe the fear that if they speak out these intrusive thoughts, it's as if they might happen. Often there's a sense of, can I trust myself? And my mind feels like a battlefield. You know, sort of, you know, OCD could be characterized as a tyrannical noise, dictating the feeling of not getting everything done often, or feeling I'm never quite doing enough. And I quote, your study suggests that cognitive conceptualization of OCD and the notion of intrusive thoughts differ in meaning and responses between clinical and non-clinical groups, rather than their occurrence. Could you say a bit more about that?
Yeah, so I think you've sort of touched on, you know, one of the important concepts about how people experience thoughts is really key. So this idea of kind of thought action fusion, if I say the thought, it might come true. So there are associated concepts really well known within OCD. It's how we think about thinking. We all have, you know, assumptions about how the world works, and then if you get an intrusive thought, those things come online, really come into play. There's some really kind of nice work from a person called John Abramovitz in the States, looking at, you know, how people's beliefs about the importance of thoughts and so on, and they got people in a sort of antenatal clinic to fill out some questionnaires on that, and they found that those beliefs then predicted how distressing people found intrusive thoughts later. So given that thoughts are very normal, ubiquitous, what is the difference between a person who is bothered by them and not? Why do they stick around for some people? And we think it's at that level of meaning. It's what you make of the thoughts, which is a key, obviously key idea within cognitive theory, which was obviously stolen from the Greeks and, you know, ancient philosophy. So, but it's a really important idea. It's what meaning is being given to them. So if you have a thought, if you have an image of harming your baby on purpose, that's going to be quite unpleasant for most people, but they might not assimilate that into a particular meaning. It doesn't feel like that they need to do something, because it's that meaning of, well, perhaps having this thought in my mind, that's some indication that there's something horribly wrong with me. I'm a terrible person. And it's holding that horrible fear in your heart that then starts to drive the behaviors. So in a way, we'll say that the thoughts aren't really a problem in themselves. We can't really, you know, they're going to pop in. It's that meaning that really is the engine room of the problem. I would always kind of think about it that way. It's that meaning which is actually driving the fear, the shame, the disgust. It's that meaning which is saying, I'm just going to kind of give my baby to my partner for a little while, because they're probably better off with them, and kind of, you know, many examples, you know, poor parents who've kind of somehow found a way for months to have someone with them all the time, and they, you know, they lose that confidence in themselves. I think you touched on that just now, is that idea that I can't trust myself. So OCD manages just drip by drip to say, well, better not try that. And it's too important to test out, because what if it's true? And holding that idea, even if I tell my thoughts aloud, I can't tell Fiona, I can't tell Connie, you know, that act of disclosure, they will know. At best have the baby taken away. Perhaps, you know, they don't really know me. They're going to give me some reassurance and it's not correct. And because I know, you know, these thoughts mean something awful. So, you know, this is coming back to these sort of first disclosures, our ability to detect and normalize these thoughts and help people understand that in a different way, help people understand that that meaning is what's driving it, and then unpack that meaning. What kind of person does worry about their thoughts? You know, what kind of a mum is so worried about this that actually she's doing everything she possibly can to stop harm coming to their baby. I think if you can get people to pause from that terror and just step back and think about what they're experiencing, it can be very powerful. They might not believe you straight away, but you can start that dialogue. Maybe there's a different way of understanding this. Maybe OCD is telling you these thoughts mean you're a terrible person, but maybe these thoughts mean that you're afraid of that. It's actually because you're very connected and you're doing everything you can to be a good mum, that you're so alive to these other possibilities. So treatment really is a big sort of reframe of this, but really based on that meaning. So quite often people will come and say, if only I could just get rid of these awful thoughts, I will be fine. We have some very disappointing news that actually that's not what we're going to be trying to do. We're going to be understanding them and trying to understand that very idiosyncratic meaning. And maybe there's other things that have happened in the person's life that they feel this is confirming. So actually there's a fair amount of unpacking to do. So, why does one person worry about this, not another? There is going to be a whole story there. Why is it that these thoughts feel important? So yeah, there's a fair amount to it. I hope that's given a reasonable explanation.
Such a comprehensive answer. I want to ask about treatment, but first I was going to, you've mentioned that your study on the quality of parent-child interactions and what you've just been saying, I think, is that the impact on a woman's experience of parenting in the areas of confidence and a sense of managing. But the clinical group and your research shows similar levels of parental warmth and responsiveness. And it led me to think, as you were talking as well, that the other area that's perhaps not touched on, but I've thought about, was the role of the baby's temperament and the mother's traits, and how this might also influence regulatory problems and things such as complications of feeding, which can also contribute to some issues for parents. But yes, I wanted to ask about what, in your mind, is effective cognitive behavioural therapy. You've mentioned a little just now, but could you sort of just tell us a bit more about, as a clinician as well?
Yeah, I think there are some general elements and probably some specific elements, but not loads. And I'm probably going to make it sound very simple. And I think that we all know, whether you're a service user or a practitioner, that it's a framework, isn't it? And life is rarely simple. But I think establishing trust is the absolute foundation. And what do we mean by that? It's having some knowledge and understanding of what that person is conveying to you. I think that's very helpful. OCD is very sneaky, and it can detect doubt, clinician doubt, quite effectively, I would say. So I think, for us to understand the problem and really going in there with confidence, and I guess it's something we accrue as we go on, but believing in these models and conveying to the person that this is understandable is really important. But to do that, we have to actually understand what they are going through. So the first stage is that sort of shared formulation. And in the way I've been taught to do it, I think is very explicit. And we're doing a formulation together. We draw it out with the person. We make sense of it together. There's nothing hidden about that. It's like, you're the absolute expert in what's going on for you. I know a little bit about OCD. Let's get our expertise together and try and understand how this problem is getting you to do things that on one level you think aren't reasonable. So we start off with this sort of paradox, I suppose, that runs all the way through, because I think, generally speaking, people can be very severe, but they're coming to us because they don't want to be that way. So we want to capitalize on the fact that in the moment it's so difficult, but stepping outside it, there's other ways to think about it. And of course, within treatment, we want to bring those things together, and we want the reflecting self to be able to start to call the shots a little bit and guide the other part. So that that stage of really understanding is super important. Getting that formulation, getting to that meaning, thinking about an alternative meaning, a credible alternative. That's we call, technique is theory A, theory B. It sounds super simple. We have one way of thinking about it like this, and we have another way of thinking about it like this. It can take several sessions to build a really credible alternative. So if OCD is telling you you're a terrible person, that you could make a mistake at any time, you could mess this up, you could harm your baby. So that's what the center of it, that's been their lived reality. We need to think about this credible alternative, that actually you've become really afraid that you're going to make a mistake. You've lost confidence. I will often have that within this alternative framing. And we'll just think about it together, those two things. So setting up the structure for the active part of treatment is absolutely crucial. We can't go into change before there's a framework for change. So to my mind, that is essential. And we need to know we need to have that credible, we need to have that firm, we need to think, what is it that tells you that this idea of being a horrible person is true, and what might fit with the other side? Really sort of explore it and lay it out kind of together. And then the next phase is acting on that. Insight is not enough. It is absolutely not enough. Because to some extent, I think people have insight. It's how do I actually really use that to make a difference and start to go against it, face the fears, stand up to the OCD bully. There's a whole raft of metaphors. It's not easy. If it was, I would be out of a job very happily. It would be great, but OCD isn't like that. It will come back with all sorts of things, but we need to put that knowledge into action. So the doing phase is really important. And again, OCD is a very sneaky type of problem. It can get therapists and service users, I think, stuck at any stage of the process. I just need to get this perfectly right. I need to feel completely understood. So I think if you notice that we're dealing in extremes, then it's probably quite a good clue that OCD is, somewhere tapping us on the shoulder. This is good. If you try and get it perfectly right, we're never going to end. That we need to get it good enough so that we can actually make those changes. And in fact, part of the treatment is being able to tolerate good enough. And so doing the active part is really important. And, doing the behavioral experiments, doing the kind of exposure, finding out how the world really works, standing up against those thoughts. So for us, like, not reassuring people, it's like, okay, we've got this theory, we've developed it. How could we test it out? What do we need to do? And it's kind of standing side by side with your client, your service user. I mean, of course, they have to do the hard work, but we're not going into this blind. My pretty good guess is this is OCD and you're a fantastic person, but you don't build confidence by talking about it. You have to build confidence by doing stuff. You have to be alone with your baby. You have to bring on the thoughts. You have to be able to say them out loud. This is where, I'm going to say my own thoughts out loud. I'm going to wish terrible things on my family. Believe me, I've tried to kill them many times. Because if we can't walk the walk as the therapist, how can we ask our patients to? It's much more terrifying for them because they are in that belief system where OCD is saying it's truly dangerous for you to do this. So I think all of those elements. I'll stop there. I could carry on all day.
I found myself wondering what tools some of your clients have sort of felt they've gone away with, where there are things almost like a kind of tools that they can draw on if they feel vulnerable at a particular life change or a crisis.
Yeah. Well, this is where having the actual active experience and knowing that you can cope with it is very handy, I think. It gives us that kind of lived, felt sense that actually I can manage this. I always think OCD lives in the space of getting people not to try, not to push against the door. Don't test things out. It's going to be too much. So if you have done that, you've got a lot to go on.
Yeah.
So of course we can't anticipate, everything in life that's upcoming, but you have a skill set where you've actually pushed against it. And what does it do? It runs away. And that's how it works. OCD is brilliant at getting people not to try. But if you've done that, it doesn't change how you fight OCD. So we can, it's really helpful, I think, to think forward, what might be difficult times and what would you do? How would you use this knowledge? Let's just think it through. And the more you're forearmed, the less you really need that, because it can't take you by surprise. But it's still good to be thinking that and be thoughtful and deliberate about what you might do. And this is where things like, let's hope there isn't another global pandemic, but that was obviously pretty challenging as in terms of a kind of something that would coincide with a lot of OCD fears. So, thinking about where the average is, what do I need to do? What would be excessive in whatever situation you're in can be super helpful. What would OCD really like me to do? Go and hide in the attic, I guess, and never speak to anyone again. It's like, well, that's not going to be good. So yeah, thinking through all of these things is a way of really embedding it. But if you haven't done that active work of testing it out, much more difficult.
Yeah. Finally, you mentioned in preparation for this talk about your collaboration you did with some women in and their experience who were mother and baby units. And for the audience, these are specialist inpatient units for someone with mental health problems during pregnancy or after the birth of their child. Could you say, what drew you to collaborating with them and what you learned from what your research showed?
Yeah, so I mean, I've worked for a long time in kind of specialist anxiety disorder services. And so would see perinatal clients within that, and quite often people who'd had the experience of being on a mother and baby unit, which are wonderful places, actually, and so much expertise in supporting women. But I think the nature of OCD can make it challenging because that's not a very common diagnosis to have in those settings. And often people might be admitted to those settings because they are in a crisis and there's lots of concern about them. But I think for lots of reasons, it can be a difficult experience. So I wanted to do a bit of research speaking to both women who'd had that experience with perhaps different forms of OCD, and the people who, from various disciplines, who were providing care within that setting, to try and think about what would be best practice within an MBU. Could we kind of think about those experiences, whether positive or whether more challenging, to actually kind of, improve the experience for those women who will be on MBUs. So that was the sort of origin of it. So I had a wonderful clinical doctorate trainee, Ella Davenport, who conducted the research and did a great job. And we had women with lived experience kind of advising on the topic guide for the interviews and how best to approach women. So we really, of course, wanted to embed that lived experience through the whole process. So Ella was great, and she managed to interview, I think, about sort of 8 to 10 women who'd experienced that from different MBUs throughout the country as well. So that was quite important. We wanted, because the geographical spread and so on, it's important. So trying to get as much diversity as we could. And I think spoke to most of the professional disciplines who were working with women, because obviously people have different roles in terms of the care. So so that was the method, really, just so qualitative interviews, asking people about their experiences and so on. So I think there were some important finding. It's still under review. We haven't published it yet, so hopefully that will be out at some point soon. But I think there was, acknowledgement of the difficulty of a problem like OCD within a unit that, of course, has to go with certain rules and, providing individualized care. There were kind of issues about how much support is helpful, I guess, in terms of offering reassurance. So things that might be absolutely what's needed in the context of a different type of presentation for where women with OCD might have, be worried about looking after their baby. There was so much support there that actually it might have helped, inadvertently, for example, just sort of perpetuated that real testing out. So what I was just talking about in terms of building that confidence, needing to be alone with your baby and so on. So in an environment where you're not really left alone, how do you manage that? And sort of, knowledge of OCD, knowledge of the different types of OCD, being kind of communicated to all the team members, that person's specific plan and so on. There were sort of recommendations like that, but several of the women spoke about they didn't feel that they shouldn't have been admitted to the MBU, but they felt quite strongly that what they had really needed was community-based support at a much earlier stage. And that really kind of stood out. So actually we're talking about things that it was, that could have been prevented, I think, in their view. And of course there might be all sorts of reasons for that, and resource is a very real issue, but they sort of had felt that perhaps an intensive community-based early intervention might have avoided the need to go into the unit at all.
Yeah. And as we draw to a close, what is next for you, or what are you working on at the moment that's of interest?
A couple of plans in the pipeline. So hoping to develop a low intensity intervention for people with intrusive thoughts. So perhaps that early intervention, very early intervention that might have been useful for some of those women, something that could be like used as a standalone program, but with therapist support, but used in different settings. So maybe talking therapies, but maybe within health visiting settings and so on. So the idea would be to test that out and make it have lots of input in the development, but kind of make it something that could be used in different areas. Yeah, I think more on kind of working with these things in pregnancy as well, and picking up at that early stage, kind of become more and more interested in, can we really prevent things escalating? If we equip people with some of these skills at an early stage, actually, does that help? So yeah, a few projects sort of related to that. If we can identify women early, I've become very interested in doing intensive treatments. So whilst there's a certain number of hours are probably necessary to be able to deliver a treatment, why don't we do those hours in a shorter space of time? So the pilot trial that I did included OCD, but also other disorders, PTSD, panic disorder, social anxiety disorder. And we were doing these kind of condensed intensive treatments in a shorter space of time. So really doing most of the treatment over 2 weeks. So if you can get a good change in that amount of time, perhaps we can help people through the rest of the stage, the perinatal period. So that's also on the cards, scaling that up.
Brilliant. Fiona, thank you so much. I'm going to put links to maternal OCD on our webpage, and links to your publications. But it's been such a pleasure. Thank you.
Thank you. And yeah, maternal OCD are wonderful for resource dissemination. And Diana and Maria are just two fantastic individuals who've done so much in the raising awareness. I'm very proud to be associated with them.
Thank you.